Hello, everyone. This is Jeanette Gass from IASP, and I would like to welcome you to today's webinar. Today's webinar is the first in a series it's the second in a series related to the 2021 Global Year about back pain. Before I introduce our speakers, I wanted to bring your attention to some information that appears on these slides. There are several ways to participate in the webinar today. After the talks, we will have a Q&A session, and you can type your questions into the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like. We will also be recording this webinar and it will be available on the IASP website. You can also tweet using hashtag Global Year 2021 and follow IASP Pain and Flippin Pain on Twitter. Today's webinar is brought to you in partnership with Flippin Pain, a UK-based public health campaign that aims to change the way we think about, talk about, and treat persistent pain. IASP and the Global Year campaign are pleased to be working with Flippin Pain on this educational effort. Before I turn it over to the Flippin Pain team, I would like to let you know about some upcoming IASP events. Next week, IASP will provide free virtual education on COVID-19 and pain. In June, IASP will provide its 2021 Virtual World Congress on pain. Last, we invite you to join IASP and take advantage of all of our resources. Now over to the Flippin Pain team.
Thanks, Jeanette, and thank you very much to IASP for having us along today. My name is Felicity Thou, and I'm a UK-based physiotherapist and also a member of the Flippin Pain team. Flippin Pain is a campaign aimed at raising awareness of persistent pain, but also flipping people's understanding of it. And we do that through our various website resources, sharing real stories, and live events like this one. Today we'll be hearing from Professor Cormac Ryan, our very own community pain champion, and that will be followed by a live question and answer session with you, our audience, and our panelists, who I'll introduce a little later. Please feel free to type your questions in the Q&A box you'll see on your screen anytime throughout the presentation, but do be aware that we can't offer any personal medical advice. And so to the main event, I'm delighted to introduce Professor Cormac Ryan, Professor of Clinical Rehabilitation at Teesside University. Thanks, Cormac. I'll hand over to you.
Thanks, Felicity. Hi there, everyone. It's a real pleasure and honor to be speaking to you today. So as Felicity said, my name is Cormac Ryan. I'm Professor of Clinical Rehabilitation at Teesside University. I'm also the Community Pain Champion for the Flippin Pain campaign, a physiotherapist, and a pain researcher. This is where the technology always gets in the way, and we try to move a slide and it's not too keen on moving, but here we go, there we go. So I don't need to tell anyone on this talk that low back pain is a huge problem. It affects 7.5% of the world's population, which equates to almost 600 million people. It's one of the leading causes of disability worldwide, regardless of where you live. Clinical guidelines at the moment very much encourage a biopsychosocial approach to back pain. Over the past 30 years or so, there's been a huge shift towards encouraging active physical and psychological therapies like education and exercise, as opposed to biomedical-based interventions. However, that's not what's really happening on the ground. If we look here at the UK, for example, we see a continual increase in biomedical-based interventions. We see a 127% increase in opioid prescription in the past 10 to 15 years here in the UK. Over a similar time frame, we see a doubling of surgery for back pain in that time. So why is this? Why is there this huge discrepancy between what the guidelines say, in other words, take a more biopsychosocial approach, and what is actually happening on the ground, which is increasing biomedical interventions? Well, to explore this, I want to tell a story about my own life. So when I was a teenager, I had a long-term health condition, and my parents were quite distraught. They brought me to various consultants, and I was on all sorts of strong medications, but nothing really worked. Then one day on national radio, my mother was listening and she heard about a faith healer called Mary, who was touring around Ireland And she was over from the USA and she was having great results. So my mother thought, well, let's give this a go. So we all got in the car and drove to the Spa Hotel in Lucan, which is just outside Dublin. And you'll see a picture of it there on your screens. That was about a 2.5-hour drive. And when we got there, I went in through the door. It was absolutely jam-packed. We took a ticket on the door, which was our sort of number in the queue to see Mary. And when we went into the main auditorium, I was slightly despondent to hear that Mary was only on number 100 and my ticket number was 850. So it was going to be a long night, but I thought maybe Mary was going through them pretty quick. That didn't turn out to be the case. And about 3 hours later, Mary was only on ticket number 400. And it was about 11 o'clock at night. And my parents were starting to get worried because we had a small farm. They had to go back to tend to the animals and indeed my other siblings. So my mother, as all mothers will tend to do, kind of gave me a bit of a nudge and said, go and see if you can get seen earlier. So I dutifully went up to one of the stewards and explained the situation. I said, look, we've come a long way. I've been here for a long time, but unfortunately, I now need to leave due to farming commitments. Is there any possibility of seeing Mary before I go? So he passed on this request to the next steward, who passed it to the next one, and it rippled all the way up to the main stage where Mary was with the chief steward who was chaperoning her around. And he looked down at me with a really piercing gaze. I still remember it very well. And he gave a slightly perceptible nod, just sort of a bit like the man from Del Monte. And sure enough, I was in. That ripple of information came back down that I could come up in the next batch. People were being called up in batch numbers. So the next batch was called and the steward kindly brought me up the aisle, sort of bypassing the main queue. Now, as I skipped along with youthful exuberance up this queue, I began to feel a little bit uncomfortable as I looked in the seats of the people I was passing, who were quite ill and a lot of old, frail individuals. And I could see in their eyes as I was going by what they were thinking. They were thinking, what's wrong with this poor boy? It must be something terrible that he's having to be rushed up ahead of the queue. Maybe every second counts, best of luck, son. And I started to get a little uncomfortable. When I got to the top and I met the man from Del Monte, his role was to ask what the problem was. Then I was meant to announce it to the group, and then Mary was meant to do her thing. So he was looking at me with those same expectant eyes. This must be something awful to have needed to have jumped this queue. So when he got up there, when I got up there, he said, "What's the problem, son?" To which I replied slightly sheepishly, "Acne." And he double taked. I guess this guy had probably heard it all. So it took a lot for him to double take. And you could tell his eyes changed away from poor boy to really, you jumped this queue. You bypassed all these people who need bypasses themselves with acne. But before he could get any of that out, Mary stepped in, the professional that she was, and laid on hands and did her thing. And then we got out of there before we were lynched by the man from Del Monte and ticket holders 400 to 850, who are probably still in that queue in the Spa Hotel in Lucan to this day. As I reflect back on that event, a number of things struck me. First of all, that event really scarred me for life, a little bit like the acne, but it also make me understand how important our belief systems are in terms of the healthcare that we access. The Ireland of my parents' generation was very, very religious, and faith healers were not uncommon. They weren't frontline staff, but they weren't uncommon. And within the logic model of that belief system, it was perfectly reasonable to go to a faith healer with your health problem and expect a sort of a laying on of hands. Now, if we bring that up to kind of right now, think about yourself, your own situation, the back pain you have, and the clinic that you go to, or indeed the clinic that you may work in if you're a healthcare professional. I want you to replace the Spa Hotel in Lucan with that clinic. And I want you to replace Catholicism with the biomedical model. Within that biomedical model of care, and expectancy. The biopsychosocial based interventions, those evidence-based interventions, those active physical and psychological interventions, they don't make any sense. Why would you want to do something like mindfulness, for example, if you've got spinal degeneration? It just doesn't fit. The logic model doesn't fit, and thus people do not want or do not expect or feel they don't need those interventions. They need something else. And that is a huge barrier to our evidence-based practice. We need to change that conversation. We need to change that belief system. And that's what the Flippin' Pain campaign is all about. We want to change the way that people think about, talk about, and treat persistent lower back pain. In the past 50 years or so, huge steps forward have occurred in terms of our scientific understanding about back pain. But unfortunately, that information has not trickled through to the person on the street. And as such, there are an enormous amount of myths and misconceptions about back pain, which act as barriers to recovery. We believe that knowledge is power. If we could take this scientific information and put it in the hands of the people who need it the most, the person with back pain, their friend, relative, their healthcare professional at the coalface, we believe we could knock many of these myths on the head. We could bust a lot of these barriers and lead to better pain management. And when it comes to back pain, the myths are many. Have a read of some of these and think about how much you personally agree with them. And it gives a sense of where you are in terms of your understanding of biomedical versus biopsychosocial. Let's take a look at them. Things like imaging is necessary for diagnosis and treatment. Pain is an accurate marker of tissue damage. Structural displacements cause back pain. Lifting is bad. Activity should be avoided. The spine is vulnerable. All of these are myths about back pain. But because the biomedical model is so strong and so well ingrained in us, most people, many people believe these, and it heavily influences the care that they seek. So within the Flippin' Pain team, we're trying to push back against that and trying to push a different model, trying to push the biopsychosocial understanding in line with contemporary pain science. Our key messages are: persistent back pain is common and can affect anyone. Hurt does not always mean harm. Everything matters when it comes to back pain. Medicines and surgeries are often not the answer. Understanding your back pain can be key, and recovery is possible. And I'm going to touch on each of these just now. So first of all, let's start with hurt does not always mean harm. What do we mean by that? Well, take a look at this case study. It's a really famous case study at this point, published within the British Medical Journal in 1995. And it tells the story of a builder who jumped from one platform to the next. And as he did so, a 6-inch nail went up through his boot. He was in absolute agony. He was rushed to accident and emergency, where they gave him fentanyl, but it didn't help at all. So they had to cut off his boot. And when they cut off his boot, miraculously, what they found was he was completely uninjured. The nail had passed between his toes and there wasn't a scratch on him. It's a beautiful example of how you can have terrible pain, but little or no injury. And then in contrast to that, here's a situation where you have terrible injury with little or no pain. So this is an account published in the journal Injury Prevention of a man who found a 12-centimeter knife stuck in his head. And basically, he was experiencing some headaches. He went to his A&E and they took a scan, and that's what they found. Essentially, he came home one night a little tipsy, and when he woke up that morning, he could find the handle of his favorite knife, but he couldn't find the blade. No prizes for guessing where it was. But a couple of days later, they surgically removed it and he left and he was fine. But it's a perfect example of really significant injury with little or no pain. Hurt does not mean harm. And you might be thinking, okay, these are two freak sort of accidents or events that are not about normal people. They don't relate to normal people like me. So that's why I've also thrown in this story about Felicity. So Felicity, who you met just at the start, who's kind of comparing today's event, Felicity was out walking her dog, Jim. That's not the dog's real name. I can never remember the dog's real name, but let's call him Jim. And Jim saw a rabbit. He essentially pulled on the leash, which knocked Felicity over. And as Felicity fell over, she broke her collarbone. And she reports at the time experiencing little or no pain. She reports a sort of a crunching sensation and a feeling of nausea, but no pain. Hurt does not mean harm. They often hang out together, but they are two separate entities. Now, how is this possible? We'll get onto that in a minute. But what I'd like to kind of draw attention to is the fact that this matches back pain very, very well. We know that 9 out of 10 people with lower back pain have significant pain, but little or no identifiable structural pathology. That's because hurt does not mean harm. So the next message is tries to understand some of the reasonings behind that. And it's because everything matters when it comes to pain. Essentially, understanding that pain is a biopsychosocial experience. But to explain that, I'm not going to start by talking about pain. I'm going to start talking about vision and our visual system, because our visual system and the things we see are a biopsychosocial experience too. Take a look at this cube, which is an illusion. What I've done is I've circled 2 squares on this cube. The one at the top appears to be brown. The one at the side appears to be orange. Now, when I throw a sort of a white sheet over the picture, just exposing those 2 squares, both of them now appear to be brown. Now, I can guarantee you I haven't changed the color of those 2 squares. I've only changed the picture around them, and they appear to have changed color. How is that possible? It's all to do with how we see. So light reflects off images in the surrounding area, goes in through the lens of our eye onto the retina, where it stimulates rods and cones, which convert that light information into electrical information, which sends that electrical information via the optic nerve to the part of the brain that deals with vision. I want you to imagine that in there is a little girl called Sheila. Sheila's surrounded by millions of jigsaw puzzle pieces. And as that light information comes in, she uses that information to build in real time a jigsaw puzzle that creates the image that you see. So don't think of what you see as an input to your brain. What you see is an output of your brain. It is a creation of your subconscious mind. And it is influenced, of course, by that light information coming in, but it's also influenced by your previous experiences, expectations, beliefs, and attitudes, what you think. All of these influence the image that Sheila creates for you. And all our senses work like this, whether it's taste, touch, hearing, etc. Let's dig into this a little bit more and look again at that visual illusion. On the left of this square, you'll see a dark, shadowy or shading area, suggesting it's in shade. And that would also suggest that over the other side is a really strong light source. Now, that's not the case. This is a 2D image, but Sheila doesn't know that. And she's used to dealing in 3D. Now, when light reflects off these 2 circled squares, both of them are in reality brown. So the same amount of light energy is reflecting off both and going all the way into Sheila. She would usually make the assumption or the prediction that they were both the same color, both brown, and thus that's what the image she would give us. However, everything matters when it comes to what you see. What you see is a biopsychosocial experience. Sheila takes into account the fact that the side square is in shadow. Now, if you're getting the same amount of light energy, but one of them is in shadow, then she makes the assumption that it must be brighter. And thus she predicts or assumes that it is orange. And thus that is the image that she creates for us. So we see an orange square and a brown square. Now, when we throw back over our white sheet, Sheila has a much easier job to do. Now she's getting the same amount of light energy from the same 2 squares, but she no longer has to adjust for the influence of the shadowing. And thus it's easier for her just to say, same amount of light energy, must be the same color, must be both brown. That's the image she gives us, which is the truth. In reality, they are both brown squares. It goes from being a 1,000-piece jigsaw of the sea, really difficult to get right, to a 4-piece jigsaw of a cow. So what we see is not necessarily what we get. It is our subconscious brain's interpretation of what is there that we get. Vision is an output of our subconscious brains, not an input, and all our senses work in a similar way. Now, I want you to start thinking about pain as one of our senses. Don't think of pain as an input to the brain. Pain is an output, a creation of your subconscious mind. So let me introduce you to Assumpta. Assumpta is Sheila's first cousin on her mother's side. Assumpta is the part of the brain that deals with pain and the creation of pain. She's like our brain's Department of Health and Safety. With her weighing scales, as danger messages or nociception come up from the body, Assumpta asks the question, how dangerous is this really? And she weighs it up with previous experiences, expectations, beliefs, attitudes, and what you think. She weighs all that information up, and then she sees on balance, if she believes that the tissues are in danger, she will want to draw attention to it and get something done about it, because the purpose of pain is to protect you. I'll say that again. The purpose of pain is to protect you. As a result, you experience pain in that area. Now, in contrast, if when those messages come up and Assumpta weighs it all up against previous experiences, expectations, beliefs, attitudes, what you think, if she comes to the conclusion that the tissues are safe, she will not want to draw attention to it. She'll not want to get something done about it, and thus she will not produce pain. It's as easy and as difficult to get your head around as that. What evidence do we have that Assumpta exists? Well, there's plenty of different places you can go for evidence of Assumpta, but my favorite study is this one, and it was published about 10 years ago by a group from Oxford. And I like to think that the setup of the study was a little bit like this scene from Goldfinger, that James Bond film. So participants had a laser shone onto 3 different areas on their foot. When it was shone onto the first area, all the scientists in the room went, yeah, that's fine. We can use that area for the rest of the study. That's perfectly safe. Then they shone the laser onto the second part of the foot. And they went, ooh, no, we can't use that. That's not safe. The skin is too thin. It's potentially could end up in a burn. It's too dangerous. We can't use that. Then they shone it onto the third area. And they kind of looked and they all stroked their chins and eventually went, okay, we think this is sufficiently safe to use for the rest of the study, but we're not 100% sure. We're going to monitor it very, very closely. Then over the next sort of 15, 20 minutes, they shone the laser onto area 1, the perfectly safe area, or area 3, the potentially unsafe area, a number of times, and each time they asked the participant to say whether they experienced pain or not, and if they did experience pain, how much pain did they experience? And the participant was aware and viewed all of these shenanigans. What did they find? Well, what they found was when the laser was projected onto area 3, the high threat area, people were more likely to report the stimulus as painful. And what's more, they were more likely to report that higher levels of pain compared to when they reported the pain, the stimulus as painful for the low threat area. What they didn't tell participants until the end was that both areas were exactly the same in terms of the stimulus and safety. There was no difference between location 1 and location 3. The only difference was the participants' perception that one area was safe and one area was not. What we think has a huge influence, not just on how we respond to a painful experience, but actually whether or not we experience pain is influenced by our thoughts. And the amount of pain we experience is influenced by our thoughts. And that's a really, really powerful thing to know. So if we move on to a little bit of the underlying physiology of this, imagine if you're in a car accident and you get some trauma to your lower back. That stimulates some nerves in your lower back saying danger in your lower back. And that message gets sent to the second order nerve in the pathway, which sits in our spinal cord, traveling up towards the brain. And to pass the message on from the first nerve to the second nerve, we release little neurotransmitters which pass on this message and send it from the first to the second saying danger in your lower back. And that reaches Assumpta. And Assumpta asks the question, how dangerous is this really? And if on balance, she believes that the tissues are in danger, when she takes into account everything, the entire context, if she thinks the tissues are in danger, she'll want to protect them, get something done about it. And the best way to do that is to produce pain. Now, all of this happens in a split second out with your conscious control. When she produces that pain, you, the conscious you, the handsome devil you are, becomes aware of that and you react, you do something about it. Now, Assumpta has a huge amount of control over that alarm system. If Assumpta believes that the amount of danger messages coming up is not enough, it doesn't indicate the true dangerousness of the situation, she can send down excitatory messages, which actually facilitate the transmission of those messages and increase the amount of danger messages coming back up to her, a positive feedback loop. If she receives more danger messages, she's likely to believe that the situation is more dangerous and thus more likely to produce pain, to protect you. In contrast, if Assumpta believes that the amount of danger messages coming up is over-egging the pudding, it's going beyond how dangerous the situation is, she can send down inhibitory messages, which block or reduce the transmission of these danger messages. And that's a negative feedback loop, reducing the amount of danger messages going up. If Assumpta receives fewer danger messages, she's likely to come to the conclusion that the tissues are in less danger and thus less likely to produce pain to protect you. So she has enormous control over that alarm system. If we move forward from that immediate event to perhaps 6 months down the line, and that back pain is persisting, our protective pain system becomes sensitized, it becomes supercharged. Essentially, all the danger messages that want to be sent by our neuroimmune system, they overload the system. And the system can't really cope. It's not good enough. It can't send all the messages that need to be sent. It's a little bit like the post office at Christmas time. It can't cope with all the messages that want to be sent. So how does the post office cope? It employs more people, and those people work longer hours. Anyone who's been woken up by a parcel at 7 a.m. in the morning over the Christmas period will know what I mean. Now, when our alarm system physiologically also adapts and changes chemically to get better at sending danger messages. And these chemical changes that occur spill over into neighboring nerve pathways. A little bit like if your house was on fire, you might call for help from your neighbors to come and help put the fire out. If you had a problem, you might call people around you to help out. In this case, if your system is trying to protect an area, it might get other areas involved to help protect that area, meaning that the pain feels like it moves, it gets bigger. If there's anyone out there who can relate to that, who says that their pain perhaps sometimes feels like it moves or has certainly gotten bigger over time, move to a larger area, then that's a real sign that your system has become sensitized and supercharged. How do we kind of convey this to people? Well, when I'm talking to my patients, to try and convey this message that persistent back pain is not so much due to tissue damage, but increased sensitivity of our body's natural alarm system. That pain is a marker of perceived threat, and the purpose of it is to protect you. I always try and use this car alarm metaphor. Imagine you've got a brand new car and it's the apple of your eye. You've even got personalized number plates. You drive up to work, you park it, you get out, you go up your 4 flights of stairs and you start typing away. Meanwhile, a burglar looks out through the bushes, sees your car and says, I'm going to have that car radio. Runs over, breaks the car window, grabs the car radio, and then runs off down the road. 2 minutes later, your car alarm goes off. You jump up, you look out your window, you shout, "Oi!" But he's long gone. You go down your 4 flights of stairs, you call the police, you call the RAC, and the police come, take a statement. The RAC come and they replace your car window, they replace your car radio, and then the guy says, I'm going to give you a little tip. I'm going to increase the sensitivity of your alarm system. Now, the next time someone tries to mess with your car, they're going to get a rude awakening. He goes off, you thank him very much, you go back up your 4 flights of stairs and you start typing away. Meanwhile, burglar looks out through the bushes again and says, I'm going to have that one too. And he runs back over to your car, but as soon as he touches your car alarm goes off. And you jump up from your seat, you look out, you shout, "Oi!" He runs off, he gets spooked. You go down your 4 flights of stairs and you're delighted to find that your car is perfectly safe. There's not a scratch on it. And you thank your lucky stars for that RAC guy. You turn off the alarm, but you leave the sensitivity up because you need it, because it's done such a wonderful job protecting your car. You go back up your 4 flights of stairs, you start typing away. 2 minutes later, car alarm goes off again. You jump up, you look out your window, and what you see is an elderly couple have just walked past your car and glanced off it. Now, your car was in no danger, but that was enough to set off the alarm. And the alarm sounds just like it did when the window was broken. You could go down your 4 flights of stairs, you turn off the alarm, but you leave the sensitivity right up because it's doing such a wonderful job protecting your car. Then you go back up your 4 flights of stairs, you start typing away. 2 minutes later, car alarm goes off again. You jump up, you look out your window, and there's this huge pigeon sitting on your car. Now, your car is reasonably safe, and it must be a deaf pigeon because the alarm hasn't scared him off. But nonetheless, you go down your 4 flights of stairs, you shoo him away, you turn off the alarm, but you leave the sensitivity right up because it's doing such an awesome job protecting your car. You go back up your 4 flights of stairs, you start typing away. 2 minutes later, car alarm goes off again. The problem is no longer the broken window. The problem is no longer the stolen car radio. The problem is this sensitized alarm system. And whilst it is doing a wonderful job protecting your car, it's actually stopping you from doing all the usual daily activities that you need to do to function. And persistent pain, persistent back pain, works in the same way. That back pain is doing a wonderful job protecting your back and keeping it safe. But the downside is all the normal, usual activities that you do with your back are being interpreted by Assumpta as dangerous also and resulting in back pain, even though they're in perfectly healthy, happy tissues. And it becomes a real challenge. Now, positive, accurate information can help to desensitize this system. In contrast, negative, inaccurate information can actually fan the flames and increase the sensitivity of the alarm system. And there's no better example of that than scans when it comes to back pain. Imagine, if you will, a 50-year-old lady with back pain. She goes to her general practitioner. He sends her for a scan, and scan comes back to show spinal degeneration. And naturally, within a biomedical framework and understanding, when told this, the lady's quite distressed. She assumes, reasonably logically, that the spinal degeneration that is seen on the scan is the cause of her back pain. What do we think her Assumpta is going to think when that information is conveyed? How dangerous is this really? Well, spinal degeneration sounds awful. We really need to protect the back. Best way to do that is to produce pain. And so Assumpta goes into overdrive protecting that back. And that is why When we scan people, we statistically increase the risk of a poor outcome. That's a really powerful thing to remember. Scanning someone can statistically increase the risk of a poor outcome. And it's because of the way that information is conveyed. What we don't tell people is the full story. And a much neater story is shown in this table to the right. This table conveys the amount of imaging findings found in the different age categories for healthy people with no back pain whatsoever. If we look at the 50-year-old category, we see that 8 out of 10 people with no back pain whatsoever will have evidence of disc degeneration on their scans. These are just normal changes over time. They're not necessarily pathological. They're just the kisses of time, like gray hairs, etc. But within the biomedical model, they become something different. They become a real threat, which influences Assumpta and makes her want to protect the back even more. And this is beautifully described by Pete Moore, one of our Flippin pain friends. And this is an old image of him from maybe 10 or 15 years. Those of you who know Pete, he was the creator of the pain toolkit. And he gives a lovely story in this next video.
I did actually get to have an MRI scan, and it showed up that I had degeneration of the discs in my lower back. It's the 2 lower vertebrae and 1 in the centre. What it's shown is more or less like bone was sort of rubbing on bone, really. So, okay, but the words they use, okay, I guess at the time frightened me. They use this word degeneration. I think, God, well, if I've got something degenerative, and I better just be really careful what I do. So again, I had this thinking, well, if I've got something degenerated, I better not be too active in case I wear things out even more. And they also told me that when they showed me this, they said, oh, your spine is like a digestive biscuit. Again, you know, I thought if I move at all, I may make things worse. But by not moving, as I found out later on, I was making things a little bit worse, because I was becoming more and more deconditioned.
Imagine telling someone that their spine is like a digestive biscuit. It's the very epitome of negative, inaccurate information. That healthcare professional couldn't even use a robust biscuit like a hobnob, something with a bit of steel in it. As we all know, digestive biscuits just dissolve when you put them near tea. Poor old Pete must have been avoiding tea just in case his spine dissolved. This was completely negative, completely inaccurate information, which only seemed to worsen the problem. And this, you know, certainly for the healthcare professionals listening today, that should convey to you this idea of how important it is with the language we use and how we talk about persistent back pain, and how we should never compare the back to any baked goods. Okay, next point we're trying to make. Medicines and surgeries are often not the answer. Now, I want to preface this with a couple of points. First of all, the biomedical model in the right context is brilliant. The obvious example is COVID-19. The vaccine is such an important part of our way of tackling the virus, and it's our exit strategy, and it's brilliant. And we wouldn't have that without the biomedical model. So the biomedical model in the right context is brilliant. But it is a very poor fit for persistent lower back pain. If we then move in more narrowly and talk, in this case, for the short amount of time I have, we talk specifically about opioids. With short-term acute pain, let's say post-surgical pain, opioids can be really, really useful and a vital part of the toolkit. But for persistent lower back pain, they're just not a very good fit. Now, why is that the case? Well, let's talk about it more to do with in a different way. Let's think about it as fire. Okay, when a fire occurs, the person who's faced with that fire, it's noxious. They want to get away from it. They want to put it out because it's dangerous to them, and they will do anything they can, and they'll grab any fire extinguisher they can to put that fire out. However, the fire extinguisher that you use is hugely important. but depending on the type of fire it is. If it's a wood fire, for example, then a water extinguisher is really, really useful. That's what you need. But if it's an electrical fire, then actually putting water on that won't just not put the fire out. It may actually make things much worse. So it's important. The mechanism of the fire heavily influences what you should use to put it out and how effective it is. If we think about that same approach with persistent pain, or with pain in general, opioids can be really, really useful in that acute stage. But because of the different mechanisms underpinning acute and persistent pain, it becomes far less effective for persistent pain. To the person experiencing it, much like fire, it's still that same noxious thing. The sensations it creates are much the same, but the underlying mechanisms are different, which is explaining why opioids can be really useful for acute pain, but not so for persistent pain. And there's plenty of evidence to support that. A recent meta-analysis, I say recent, 2 years ago, published in the Journal of the American Medical Association, tried to quantify from many randomized controlled trials accounting for over 26,000 people, the average effect of opioids for people with persistent pain. And I asked a friend yesterday what he thought would be the average effect for opioids for people with persistent low back pain. He said about 30%. It's actually 7% on average. This study says that opioids can reduce pain by about 7%. Now, the minimally clinically important difference for pain relief is set at about 10%. In other words, if you can't improve pain by 10%, you're probably not at the races. It's probably not worthwhile. And that's pretty hard evidence against opioids. And it's an important thing to consider as we think about that message that pain medications and surgeries are often not the answer. And this kind of supports that point. Understanding your pain can be key and recovery is possible. These are my last 2 points I'm going to make today. And I'm going to do that as a sort of a winner by showing some slides provided to me by Professor Lorimer Mosley down in Australia, who kindly provided these. And this is some data from his own clinic of about 900 people, some of whom had back pain, but not all of them. And in their clinic, everyone receives pain education, pain science education, a bit like the education we've done here today, but in more depth and more detail over a longer period of time. People also receive a smorgasbord of active physical and psychological therapies. And what they found was if people on average start at a pain at about 5 out of 10, and they've had pain for about 6 years, for those people who flip their understanding of pain, after the first month, there's very little change in their pain. But over a 6-month period to a 1-year period, we see a clear reduction in the pain experience. In contrast, those who didn't flip their understanding, their pain remained relatively stable. This kind of says 2 things to us. Number one, how we understand our pain, changing our understanding of pain away from a hurt equals harm understanding to a more contemporary pain science understanding that pain is a marker of perceived threat, can help us to recover. Now, I say that cautiously because this is not a randomized controlled trial. We can't say for certain that it was due to changing their understanding. It could have been due to anything. It could have been due to changes over time or a myriad of different things, but it provides an interesting piece of evidence towards that. What it does also show is that people can change, they can improve in terms of their pain. And whether this is a randomized controlled trial or not, that point still stands, as we see about half of those people reduced their pain. Now, when I talk about recovery in this context, although this particular example is about pain, I want to make it clear that when we say recovery is possible, we're talking about recovery in its broadest sense. Recovery can mean different things for different people. For some people, recovery is a reduction in their pain. For others, recovery is being able to return to work despite their pain. For others, it's being able, just feeling better in themselves despite their pain. And if you listen to the stories of the people with pain on the Flippin' Pain campaign team, you'll find that a lot of them talk about being in recovery or being recovered, but many of them still have quite significant pain. I want to make that differentiation between the two, while still making the point that pain can change. And that's an important point to make. So we're really trying to push back against the pervasive biomedical understanding about pain and move it away from that hurt equals harm understanding towards a more contemporary pain science, biopsychosocial understanding. The key messages we're trying to convey is that persistent low back pain is common, can affect anyone. Hurt does not always mean harm. Everything matters when it comes to back pain. Back pain is a biopsychosocial experience, as all pain is. Medicines and surgeries are often not the answer. Understanding your back pain can be key, and recovery is possible. To finish up, I'd just like to thank everyone involved in the Flippin' Pain campaign, all our persistent pain, people with persistent pain within the team, all our clinicians, all our scientists, etc. And I'd like to introduce you to the question and answers panelists. Over to you, Felicity.
Thank you very much, Cormac. That was brilliant. Thank you. And hello to everyone all over the world who was introducing themselves in that. It's amazing to see. So I would, yes, like to introduce our panel next up before we head to the questions. And I'm going to come to each individually to introduce themselves a little bit further. So Chris, or Tina, Tina Price has lived experience of low back pain. Chris, would you like to introduce yourself a bit further?
Yes, I've been living with persistent pain, back and sciatica pain for the last 12 years. And I've been working as a patient advocate for the last few years, writing and talking to people about living with persistent pain and supporting clinicians in improving their care for people with persistent pain. I run a blog site called livingwellpain.net, and I've been very fortunate to be a friend of Flippin' Pain.
Brilliant, thank you very much, Chris. Next up, we have Dr. Deepak Ravindran. He's a pain consultant within the NHS and also the author of The Pain-Free Mindset. Deepak, thanks for joining us. Do you want to introduce yourself further?
Hello there, good afternoon. Thank you for having me, and it's wonderful to be here. My name is Dr. Deepak Ravindran, and I am a consultant in pain medicine in an NHS hospital for the last 10 years. And I'm also involved in working with pain services in the community in my local area, helped set up an integrated pain and spinal service. So this year and this message that Prof. Ryan has been doing is very much in line with what we are trying to do clinically for our patients in the local area. So thank you for having me today.
Thanks, Deepak. And finally, we have Dr. Lizzie Doher, who is a clinical psychologist within an NHS pain service. Lizzie, I'll let you tell us more.
Great. Hi there, everyone. It's really wonderful to be here today with people from all over the world tuning in, which is wonderful. So yes, I work as a clinical psychologist in the Lincolnshire Pain Service in the UK. I offer individual psychological support to people living with persistent pain, as well as co-facilitating pain management programs alongside my colleagues. And recently, over this COVID time, been delivering virtual pain management programs too. I also have a role in supporting the wider team in their emotional well-being, working in the service and leading the psychology team. So it's great to be here. I'm really passionate about sharing this understanding as widely as possible. So looking forward to the Q&A.
Thanks very much, Lizzie. There's a lot of questions in the box here, and if you do have more questions, do add them to the question and answer box. A lot of people suggested that, great presentation, how do we disseminate this information more easily to patients? And I guess one thing I wanted to flag early on is the Flippin Pain website. So if you thought, oh, this stuff is really good, I want to disseminate this to my network. There was a question in particular from Jason, how do we provide this information to patients? Well, on our website, we have this sort of information and all the key messages as podcasts, as videos, and as infographics, as well as all our previous events recorded on YouTube. So whether you want long form, short form, visual, audio, head over to flippinpain.co.uk and have a look at, first of all, the Flippin Pain formula, which is all the podcast stuff, and then also our resources. And the events is where we keep our event recordings too. There's a few questions from Nick who says it's a great talk and wanted to delve a little bit further. One of the things is, I'll come to Cormac on this. So what are the key components to make sure that this science outweighs people's previous knowledge? People, pain has been misunderstood for a long time, and people often have these deeply held beliefs, understandably so. How do we make sure that this information comes to them louder than what they might previously have heard?
Look, that's a great question, Flick, and there's many different answers, but I'm just going to concentrate on one, and I'm going to concentrate on the issue of relevance. Many people listening to this talk will have thought, yeah, that's all well and good information about pain, but it's not talking about my pain. My pain is different. I'm different. This information really isn't relevant to me. And I think if we want to help people to really engage with this material, we have to find some way of helping them to flip that understanding that actually this is about them. If you're a human being, then this information applies to you. Your pain, everyone's pain, works in this way. And this information is as relevant to you as it is to the next person. If we can help people to believe that the messages are relevant to them, if we can manipulate the story to make it relevant to them, that's hugely important.
Brilliant. Thank you very much, Cormac. Can I bring the same question to you, Chris, as someone who's lived with back pain themselves and has come on this journey of understanding themselves? Have you got any points that you could share on that topic?
Yeah, I mean, it's probably worthwhile me saying, first of all, that for the first 4 years of my pain journey, I was treated in a very biomedical sort of way with injections and opioids and surgery and everything else. And I remained in quite a devastating state, really. And it was actually when somebody, a physiotherapist, started to explain to me everything really that Cormac's explained today about how pain works, and made it relevant to me, and looked at my situation, and most importantly, helped me to understand and to start to recognize things in my body, reactions to stress and so on, that completely turned my life around. So yeah, it's hugely important, but I guess it's getting to know the person in front of you and to get to know them enough to be able to make it relevant, as Cormac says, really. I think that's really key.
Yeah, absolutely. Building trust, building rapport, and an individualised approach as well. I wanted to come to you, Lizzie, next for another part of Nick's question. We've talked about how we present this knowledge, and it's often a very logic-based way. As a psychologist, are you aware, can you share any other non-knowledge-based interventions, Nick's, along the lines of kind of playful learning, more emotional learning styles?
Absolutely. And I think just building on what both Cormac and Tina have said there, I think that, the logic isn't enough. That actually just intellectually knowing it often isn't enough for people. So actually having that embodied in some way for them is really, really key. And I guess I see this as a series of steps with people, like a process, that message about that sort of more the more sort of medical model has been there so long that we can kind of see this as a process, and it starting off with, you know, helping people, directing them to patient stories, such as Tina's, people who have turned around their thinking and that it's led to change for them, is a good starting point if people are quite resistant maybe to thinking about things in a new way, and definitely making it relevant to them. So as has been said, you know, helping people to reflect on their own life, and maybe really encouraging people to think about times where they've been in a situation where they've felt quite stressed or under threat, and what has that done to their pain? And then getting them hopefully to engage in some kind of activities that help with the soothing system to kind of dampen down that sense of threat, and getting them to reflect again. So I think it's actually embodying the logic into actually our lives and our experience. And another quick thing to add here is the use of metaphor is really powerful. So nothing kind of cuts through sometimes as powerfully as metaphor that Cormac's already spoken about. But as healthcare professionals, if we can pick up on the language people are using about their pain and the metaphors they might be giving us, and using those to help them really get a sense of converting this logic into a kind of more embodied feeling for them.
Oh, brilliant. Thank you very much. Deepak, can I come to you with a question from Chris, who lives with fibromyalgia himself? And he says sometimes he'll have other symptoms, something like abdominal pain, and his doctor often puts it down to fibromyalgia, which frustrates him. He's kind of, why do we put our other symptoms down to my persistent pain condition? Have you any insight on that as a pain consultant, as a pain physician yourself? Is it to do with lack of understanding among healthcare professionals?
I think that is a very good question, Flick, and I think you're absolutely right in the sense that our understanding of pain is very much, as Cormac put in, a biomedical model, which is a very flawed way to know about the human body. And it is because we as medical professionals or healthcare professionals, whether it is medical school or nursing school or physio school, we've always been taught in a way that the mind and body is kind of separate, and the biomedical model always focuses on looking for a structural cause. The new investigations and the new understanding of pain science shows that the nervous and the immune systems are very deeply linked together. There is the presence of immune cells within the spinal cord and the brain, and everything is wired to essentially protect us and to look out for threat, look out for Assumpta being active and making sure we are safe. And if the immune system is maximally present in the abdomen, in the tummy, which is where it is, it's not surprising that in patients, I've forgotten the person who asked the question, that in his case, the fibromyalgia can cause a sensitization of his nervous and immune system, and that can often manifest as a flare-up of abdominal pain. And we know that 70 to 80% of patients have a sensitivity there. So there is now the research and the finding to say that not only do we have to look and just be restricted by some medications or some interventions, we should be looking at how nutrition or inflammatory diets can cause problems or worsen symptoms, and also look at other mind-body therapies, because this all just brings to the fact that the mind and the body are deeply interlinked, and not what we really were taught in our so respective schools. So that, I think, is also a parallel education that needs to happen alongside our understanding of pain science.
Spot on. Thank you very much, Deepak. A point has come in from Annalie about our previous question. How do we get people on board with these messages? And she says sometimes we maybe underestimate our patients. They're mostly desperate for answers and buy into this new understanding of pain because it makes sense and because they've reached kind of closed doors before. And Annalie agrees that metaphors are great tools. I'd like to come back to you, Cormac, with a question from Kate, who's a midwife and deals with women who have pain during pregnancy, who often, she says, end up on heavy quantities of opioids and request early delivery because of the pain that is associated with their pregnancy. She's looking to create a service to help them manage their pain through the last few months of pregnancy, but she's wondering whether actually will it work within the time frame, the few months that she has, because there was no change in pain perception after 1 month on the slide with the study that you mentioned. Do you think it's still worth trying, even if people only have pain for a short amount of time? We're talking about persistent pain, by which we mean chronic pain, but do you think that time frame matters?
I think this information is good at any time, to be honest. It's relevant at any time. Trying to decrease the pain-related fear and anxiety that is accompanied with the pain experience is always worthwhile, because it can always be an important part of managing the painful experience. And whilst that may or may not influence pain in the short term, and our evidence would suggest that it doesn't necessarily impact upon pain in the short term, that does not mean that it can't help with all of the side effects of pain, the anxiety, the stress, the fear avoidance of activities, the reduced activity, all the negative impacts associated with pain can still be positively influenced by this sort of information. Thus, it is absolutely essential that we communicate it clearly. And I would throw in there, what's the alternative? Do we keep peddling the inappropriate biomedical explanation that only seems to ramp up the pain experience and all the negative sequelae that comes with it?
Absolutely, and as we know, if we can reduce the perception of threat in the short term, you don't necessarily need months and months and months to see that come into effect. Absolutely.
You can see very quick changes in terms of things like psychological distress, pain-related fear and anxiety. That comes through very, very quickly. It might not necessarily impact upon pain intensity very, very quickly, but in terms of those other factors, there can be very quick benefits.
Well, I'd like to come to you, Chris. As we talked about, you've lived with low back pain yourself, and also we know leg symptoms associated with neuropathic issues. Francis asks, so he or she, I apologise, is on the verge of starting either pain patches or increased steroid jabs for pain. Having viewed this insightful information, what else is on offer? Can I come to you about what else is on offer in your experience? What else you've come across for treatment of back pain?
Oh gosh, that's an interesting question, isn't it? So yes, I've been offered patches and opioids, and I've been on massive amounts of opioids at various times, and gabapentin and amitriptyline and all the sorts of stuff that other people have been on. And I have to say, at the time, it's what I felt I needed and what I was being given. Looking back, I wish that I had been taught more about the biopsychosocial side before I actually was, because the side effects for me, I used to call myself living in the land of the fairies most of the time, were just not worth it. Apart from injections, surgical options, I don't think I was offered anything else, and I'm not sure what else there is. But once you start to stop looking for those and start to understand pain, there's all sorts of things that can be helpful. So, for example, I use a lot of aids. I've adapted my house to my situation, my garden to my situation. I've adapted my life. I've made sure that I follow good sleep hygiene, and just all the different aspects of changing and adapting my life and understanding pain and understanding how to and why to make those adaptations. That just made a huge difference to me. So I'm not sure that there is, I could say, oh yes, acupuncture is beautiful, wonderful. I've never actually had it. It's more about understanding yourself, what there is in your life that you can adapt and change, and working with the various professionals in your family and society to help you make those changes. So I'm not doing very well at giving you a one answer, I'm afraid, because I don't think there is one answer. I think once you understand yourself better, how to live your life with pain, then you know that's when the doors open. So yes, I hope that sort of answers it.
I think that makes a lot of sense, Chris. As you say, well, as we've just learned, pain is a hugely multifactorial thing, and to suggest that we could just make one change and that be the end of it, then probably not in the case of persistent pain. How much do you think that, as you mentioned, developing your understanding, flipping your understanding of pain, how much do you think that helped your sensation of pain?
It's really interesting. So if I look back, so it was 4 years into my journey that my understanding of pain was flipped. If I look back to what I was like then, I'm much better now, and I have much reduced pain. A lot of that is because I've learned to adapt my life with pain. I'm not fearful of it anymore. I accept it. I understand it. So yes, I genuinely believe it has reduced my pain. In fact, once I got that understanding, I decided that I was going to go off opioids, off all medications. And I thought at that point that actually my pain would rocket and I'd be in a dreadful state. But that didn't happen. I was on a journey to gradually improve my situation, if that makes any sense.
Yeah, no, excellent. Thank you very much. Deepak, there was an interesting question from Mark, and I know you've written a book that encompasses a lot about pain and the different kind of facets of it. Mark says, does the health of the autonomic nervous system have an impact on pain? So when we're thinking about that bigger picture, what are your thoughts on that?
It's a very interesting question, Mark. And actually, I wear a second hat now, which is I'm the lead of the long COVID service. So I've got quite a good interest and now an experience in post-COVID syndrome. And I have to say that there is a large proportion of patients where I'm seeing dysautonomia, wherein there is an imbalance in how the sympathetic and the parasympathetic system play out with each other. And I would say that if, again, going back to one of my first answers, if we are going to view pain as a form of emotion and sensation that is an ultimate output of what protective and threatening stimulus we feel both from the outside and the inside, then our autonomic nervous system and our sympathetic and our parasympathetic, and if you are looking at it, the endocannabinoid system, are all wired to keep us in a state of balance. And if we are experiencing threat from anywhere, our autonomic nervous system, i.e. our sympathetic, is going to be hyperactive. That hyperactivity is meant to be only for a short period of time, but if it goes beyond a certain period of time, then it can stay persistently elevated. And we need to therefore then think of various ways to reactivate the parasympathetic system to bring it back into balance. And if you think about it, a lot of mind-body therapies, whether that's yoga, whether that's nutrition, whether that's diet, whether that is sleep, or even breathing exercises, are all somehow going to be bringing the vagal activity up to a certain threshold to restore balance. So I do think that eventually in a lot of chronic pain patients, there is an element of sensitization that occurs in the spinal cord and in the brain. And so restoring that balance using a variety of techniques is a definite way forward.
Excellent. Thank you very much, Deepak. There's a question, of course, we're talking to a global audience here, and a fascinating question. What psychosocial methods might help in older adults in low-income communities? Lizzie, have you got any thoughts on that?
Yes, I think it's a really good question. I think if we think about what the key messages are from this. One of the things that I know clinically can be most powerfully helpful to people is this idea of how we can boost that kind of soothing system and help to mitigate some of the threat system. And one of the really powerful ways of doing that is actually groups of people coming together to share experiences and learn together, because there's something about groups coming together that enables that sense of safety, security, understanding, validation of experiences to develop. And if it's possible to get groups together, whether it's over a common interest, maybe something that's of value to a group of people, and that can be a venue to actually talk about some of these ideas, and then look at there's simple sort of psychological skills that can be learnt, mindfulness being a really great one for helping people to start to find ways to help with that soothing system. And if you can do that alongside the information regarding why that might be relevant, as Cormac said, if we can help people understand why this might be relevant, and then they can do it in a supported group of people, perhaps over a common interest, a common skill, a common hobby, then I think that can be a powerful way to help people that doesn't have to be something that's very expensive to deliver or take part in.
Thank you very much. There's a follow-up question for you, Chris, just on the back of what you were saying, and just inquiring if you're happy to share. It's from Madeline. How is your pain right now, and do you take any medication for pain currently? Again, if you're happy to share that.
Yeah, no, I'm happy to share it. So yeah, right at the second, I'm in pain, and overall in my life, yes, I live with pain all the time. I'm never away from pain. And because I have neuropathic pain, I get bolts of pain. So I get quite a bit of severe pain, often during the night. I don't normally take medication, so I don't take medication every day. But if I'm having a difficult time with pain, so if I'm having what some people might call a flare, so a difficult week or two, then I will take medications to actually get myself through that. So yeah, but it's interesting, isn't it? When I look back at the beginning of my journey, and I had my accident, basically, I couldn't have imagined what life could possibly be. How can anyone possibly live with pain for the rest of their lives? But actually you can. I live a perfectly good life with pain. But I have been lucky, and I have had that understanding of pain, which helped me enormously. Flick, can I just pick up on the last point as well about supporting people in older adults in low income? I think that there's also something about supporting the family and the friends of those people to understand pain. So, I found in my own circumstances, I've been influenced by, parts of my family or some of my friends who haven't understood pain and have obviously tried to put their views on me. Whereas actually, if we can educate the wider population and the family of that person as well, then it can enormously help that person as well. And I think Flippin Pain has been really good about that, because they're looking at how they can support the communities as well as supporting the individuals.
Yeah, I think you're absolutely right. You can't tackle a huge problem like persistent pain just by talking to the individuals who live with it. This is a society-wide issue. So no, thank you for that. Deepak, there's loads of questions about opioids, because we touched on it in the presentation, and it's such a huge issue at the minute, isn't it, globally? I wondered if we could get your thoughts on that. And there's a few kind of general opioid questions, which I wondered if you could just kind of talk in general too. But also there's a lot of frustration, understandably, again, from people who seem to just get their dose increased and increased and increased when they're living with persistent pain. What would be your advice to someone who actually wants to break out of that cycle?
This is a real problem in terms of the opioid crisis that we've seen in the US and we're seeing in parts of Europe. I think in many countries around in Africa and Asia, I think there is a lot more control. So I'm hoping that it won't be so much of a problem there. The difficulty that we have, Flick, is that often most services have been geared and maintained to provide drugs quickly. So for a lot of general practitioners as well as specialists, opioids becomes a choice of one treatment just to keep patients somewhat comfortable. And as Cormac has pointed out, the drugs are at best effective only 20 to 30% of the time. And if there is the perception that, or rather, we know that pain can often be amplified by context and by what else is happening around us, then I think in a lot of places, it is about making sure that there is a team to support these patients and provide them alternative sources. I think if somebody is struggling with pain, asking them to just taper the opioids or won't give any more opioids is the wrong answer. As a society, as healthcare systems, we will have to invest to support these patients. We will have to make them aware of what are the other alternatives. I hope that there would be more opportunities for other countries who are looking at this webinar to take the principles of what Flipping Pain is doing to actually start providing and making people aware of other options to manage pain rather than just opioids. And then when you have that framework, that's the time to start talking to the people about what else you can do and how to taper drugs off. If we just try to reduce drugs without giving people something else tangible to believe in that they can access easily and safely, then it will always be distressing, and that is just going to amplify the pain more. So I share the concern that a lot of people have been asking about opioids. Obviously, I can't make any specific suggestions there, but I think this is a lot on healthcare systems to improve themselves and take this new finding and make alternative frameworks available.
Excellent, thank you very much, Deepak. A point from Scott in the comments here. It goes to show the power of pharmaceutical companies, given that these things only offer 20 to 30% pain reduction. Yes, there's a lot going on in the background, isn't there, among opioids. There's a point from Maria. So often, no, Lizzie, we're thrilled to have access to a clinical psychologist for this event. If you're someone working in an area that doesn't have psychology access to a clinical psychologist, for instance, what are your tips for, say, physiotherapists or pain nurses or physicians who are working, as I say, without that access?
Yeah, I guess that's true in a lot of areas. I think there's a number of things. I think the first thing to say is, again, going back to this idea of the difference between the feeling of threat and safety, is that any clinician, any healthcare professional working with someone with persistent pain, can do a lot of good and won't go wrong by just really listening, providing that space, if they're able to, the time, and also creating a safe environment for people to actually feel soothed and be able to talk to you about how they really are thinking and feeling and behaving in relation to their pain. So I think it is tricky. I know often healthcare professionals can be nervous, understandably, of opening up, talking about thoughts and feelings and behavior in relation to pain. But I would say that if that can be done in a safe way with enough space to talk about it, it's really can be important, because we know that a lot of what drives understandable but often not helpful behavior, such as stopping exercising, stopping moving, not seeing friends, not engaging in things we value and enjoy, are the difficult thoughts and feelings, whether that's beliefs about the pain or just feeling anxious and therefore avoiding things. So I think it's really important to create an environment in which someone can talk about those things. And even then, if it's just acknowledging them and helping people see that, these beliefs might be driving some behaviors which are completely understandable, but perhaps not that helpful in the long term for them. And then thinking about ways in which they might be able to just get a little bit of distance from those thoughts and feelings. So, you know, things like mindfulness practice can be really powerful with that. And there's all sorts of mindful practices people can engage with, you know, certainly lots through the internet. If you type in a search, there'll be lots that's thrown up. And I think anything that people can do which will help engage that soothing system can be helpful. And as healthcare professionals, even without having psychologists to then pass on to or refer on to, we can make our consultations a soothing, safe environment to explore some of these concepts further.
Oh, brilliant. I used to hear a lot from physios, oh, but I'm not a psychologist, so you know, how could I possibly delve into the nitty gritty of someone's emotions and feelings? But actually, we all work with human beings, don't we? So we have to get comfortable in that zone.
Yes, absolutely.
A question from Sarah in Iran, and it echoes a previous question. Apologies, I can't find the name of it now, but the issue that therapists, that Sarah says in Iran have, is that most people just really implicitly trust their doctors and the biomedical diagnosis. And people want fast therapies. They want a quick fix. Again, understandable. And so surgery is often done when actually possibly this sort of approach would be more helpful. What are your thoughts on that, Deepak, and how can we address this more widely? As these are cultural beliefs embedded in big communities, in nations. Do you have any thoughts on that?
I think it's a very relevant problem, and I come from India, and I know how deeply entrenched the word of the doctor is, which is why all the more reason I think physicians like me, they are increasing in number in many countries, where we are realizing that we do need to change how we say things. We do need to make sure that we avoid nocivic information, or i.e. words that like Pete Moore heard, crumbling digestive biscuits, or grinding, or bone on bone. I think this is something that has to go back towards medical education. And I'm proud that the Faculty of Pain Medicine in the UK is doing that. We are now reaching out and teaching the next generation of medical students on this new science, trying to make sure that the information that we talk about is not biomedically grounded and risks making people anxious and afraid. Because you're right, once that template has been set and the doctor has said that, it's difficult for other healthcare professionals to change it. But it has to, so there is one way of bottom up, wherein you reach out to the medical students and change education that way. The top down way, which I was putting on the side there, is I think healthcare systems, if we need to look at value-based healthcare, how do you do holistic, good quality, integrated health there, then we need doctors and their incentives to be aligned in such a way that they realize that everyone works for the health of the patient, which means they take on this new science, which Flippin Pain is reaching out to incorporate into their practice. And in a way, if you think about it, we don't want these existing doctors and surgeons to also feel threatened that if they say this, they won't have a role to do. We'll have to empower them and make them part of the team, so that they become part of supporting the patient through the pain journey, rather than suddenly realizing they're not going to do that many surgeries. I think that's something we have to be mindful and sensitive of, what everybody wants for the patient in this.
No, excellent. Thank you very much. There is a brilliant question, Cormac. I'm going to finish with this one to you. Erin could not have asked this at a better time. She says she would love to hear about our campaign strategy to get the word out broadly beyond care for individual patients. How are we aiming to change the dialogue in the community so that these messages aren't constantly undermined? Would you like to talk about our community?
Yes.
Yes.
What a cracking question. Thanks a million for that. So community engagement is what the Flippin Pain campaign is all about. If we can reach out to these to public communities, like Chris said, it's not just about the person with pain, it's also about their friends, relatives, their employer. their healthcare professional, everyone. If we can reach out to all members of society and push this question so that everyone is singing from the same hymn sheet, and the appropriate scientific based hymn sheet that gives a contemporary understanding of pain. We're doing it in loads of different ways. So we're we used to hold face-to-face events before the world changed radically, but hopefully we won't be too far away before someday we'll be able to hold face-to-face events in community halls, etc., talking directly to the public. But whilst and during the pandemic, and I think indeed after, we're holding in public engagement events online, just like this, communicating with people in their homes. We've got our cycling peloton, which we're particularly excited about, which is due to occur on, I think it's the 11th of September, as a week-long cycling extravaganza, where we cycle. It's based in Lincolnshire in the UK, where we're going to cycle from rural town to rural town, delivering these pain education sessions with our brain bus that's traveling behind us, which is an experiential learning facility. So a little bit like the illusions that I showed in the presentation, where people can experience those illusions to understand how our perceptions are influenced by everything. And then we can help to use that to communicate the message about how pain is influenced by everything, to help to better understand a more biopsychosocial explanation, I guess. What else are we doing? That on top of that, of course, we've got our online presence. So we've got our website, www.flippinpain.co.uk, which has links to lots of other resources like the Footsteps resource, Living Well with Pain. Indeed, our sister and trailblazing campaign in Australia, Pain Revolution, of which the Flippin' Pain campaign is heavily modeled upon. We have their resources as well, all linked through our website, and kind of providing patients with access to those. And we've got our very own Flippin' Pain formula, which I'll finish up on, which is essentially a way we've packaged all the material we have into infographics and short animations and podcasts, packaged in such a way as they're easily digestible. People can come and go and constantly revisit these messages. So it's a multifaceted way of trying to get these messages out to the community. I'm going to stop there, Felicity.
I think you've covered it. Marvellous. Cormac, would you mind nudging the slide on one? Because I think we've got the our final slide.
Yes, there we go.
Past your effort, there we go. So yes, if you have enjoyed our presentation, I hope you have, it's been fantastic to be here. You can get in touch with us, info@flippinpain.co.uk with any feedback. Do check out our website, flippinpain.co.uk, and at flippinpain across the board on social media. We'd love to have you on board. You can sign up for our newsletters for information on things like the tour that Cormac has mentioned. So thanks again to everyone who's joined us. Thank you to all of my panelists, and thank you very much to IASP again for having us on this global year of back pain.